Well, thank you for inviting me, and I apologize in advance if I have a little bit of overlap with some of Tony's comments, and where I see some overlap, I'll try to go through those quickly. And I did not put a disclosure slide in. I probably should have done that, but I have no particular disclosures related to this topic. So I want to take just a minute on the macro environment piece. I know Tony covered a lot of that, but I have a couple of other things I wanted to touch on in that regard. I wanted to actually show you the board motion from, I believe it was 2014, and the APM policy that has already come as a result of that. And then touch from the therapy perspective on some of the deliberations. Tony covered a lot of that already. And show you some of the excerpts from the draft document that I find particularly relevant to a therapy physicist. We've talked a lot about the pressure on cost in healthcare. I think that's sort of an obvious one. And I think the message there is that we're not done yet when it comes to that. And again, speaking more from the perspective of a therapy physicist, where we've been accustomed to, for instance, pretty detailed billing codes, which are now being largely bundled, and that trend will continue. Thinking about it from the as my administrator has said to me many times, the focus on cost is going to eventually hit radiology and radiation oncology much harder than it has. To date, we've been thought of as revenue centers. To a healthcare administrator, most of the other functions in the hospital don't really net a net profit. There are a few revenue centers. We happen to be in two of them. When the payment structure models really flip, when we see a major implementation of accountable care organizations and similar episodic payment, or even just covered lives type payments, that thinking will flip. We will no longer be revenue centers. We'll be cost centers. We're very high cost departments. We get a pass today because we are also the revenue center. That thinking will change. It is probably better that we understand where that's going and that we're prepared with well-founded recommendations for how we practice given those pressures, than if we just close our ears and hope it goes away. So that's something that we will continue to be challenged on. Let's also acknowledge there's a lack of licensing and regulatory mandates for the scope of work that must be done by QMPs, and I'll touch a little bit on that. And then there are precedents in healthcare that have shown that tasks can be delegated without, at least if you look at it sort of in the aggregate, without undue risks to patients. Those are three what I might think of as negative macro drivers. We can bemoan them, but they're there. Then there's one, at least from a therapy physicist again perspective, that I might think of as a you might see this either way, but I like to think of it as more of a positive one. The complexity of the clinical process in radiation therapy is just many times higher than it was when I started practicing. There's a need for the QMP to be more directly involved as a consultant in that process to the other team members, and we need to then be able to have the bandwidth to do that. And that's where we can add significant value, and frankly where there's significant risk if we're not involved, and we need to be able to allocate a fair amount of our focus to those types of things. So I'll touch on that. As I mentioned, we don't have a whole lot of protection from the licensure and regulatory side in terms of mandating scope of work that only a QMP is allowed to do. This is a very abbreviated way of saying it, but I think most of you know there are only 4 states today that have licensure of medical physicists, and most other states limit the regulatory mandates for QMPs pretty much, and again, from the therapy side, to annual LINAC calibrations. And even there, it's a subset of your annual LINAC calibration. TG51, absolute calibration, and maybe a couple of other things. It's pretty limited. So we're not going to get much protection there. We can look there, but we're not going to find a lot that we can hold up to our healthcare administrators and say, you have to only hire QMPs to do all this scope of work. There's nothing there that says you must do that. What about accreditation programs? Maybe that would be the sort of the stick that we can use. And I'm a proponent of practice accreditation. I'm an active surveyor myself. I find a lot of value in it. But even there, accreditation programs do not, at least on the therapy side, mandate a minimum physicist staffing level. They'll bring transparency to the staffing level. At least I'm more familiar with the ACR process than the Astro and Acro programs, but you will at least be compared to other accredited sites in terms of, in your stratum, freestanding or hospital-based, what your staffing levels are relative to other accredited facilities. But there's not really an absolute minimum, or there's not a hard statement of, if you offer these services, don't even apply if you don't have this level of QMPs to patient ratios. So what we might wish that was otherwise, but that's the reality. I think it's helpful for us to look at some precedents outside of our own sphere. And I'm going to talk about a couple. The radiologist assistant, and notice they use the same terminology, radiologist assistant. It's not a radiology assistant. I'll show you that in a moment, what they've done, and I think that's certainly one that's very relevant here. And then the use of non-physician practitioners, as they're called generically, certified nurse practitioners, physician assistants. And even in the nursing model of care, where you have RNs, LPNs, and CNAs, and I'll show you that. We can't really ignore these because these are probably to a health system administrator, these are success stories. And I think there's pretty broad consensus that in these areas, this type of delegation has taken place without any clear link to an increased risk to patients. So if you're a healthcare administrator, you're going to look to these types of precedents and say, convince me that this isn't doable in medical physics. So here's a statement from the ART that references the ASRT and ACR jointly developed statement regarding the radiologist assistant. And they essentially say it's an advanced level radiographer who works under the radiologist's supervision to do certain tasks. Notice here the certification as an RA, radiologist assistant, does not qualify the RA to perform interpretations. So that's, I think, an important and relevant precedent. We're talking about much the same thing here. We may be comfortable, I know there's controversy with that, but we may be comfortable delegating certain well-defined tasks. Interpretation is something that should remain with an appropriately board-certified individual. Then there's the nursing model. And I'm sure there's some in the room here who are more familiar with this than I am. I have a sister who's a nurse, but that's about as close as I get to the nursing field. I think this was an interesting, again, joint statement where they've, in the second paragraph here, they're sending a pretty, I think, powerful message. Delegation is an important nursing skill. You now have registered nurses, licensed practical nurses, and certified nurse assistants in that order. As an RN, one of your skills now is to know how to delegate and what to delegate and how you supervise those delegated tasks. There are way more nurses than there are medical physicists, so there's a lot of experience already in a healthcare system with delegation of specific tasks under appropriate supervision. So I just wanted us to appreciate that these precedents are out there. These are things that that most hospitals are very familiar with, and it would not be a stretch for an administrator or a VP to come to us and say, so I do this elsewhere in the hospital, how come I can't do it here? In that same vein, one thing I neglected to mention on the cost side, but I think again is important to be mindful of. I mentioned earlier here the term non-physician practitioners, but practitioners being the key term here. At a higher level, there are sort of two groups of employees in a health system: practitioners and non-practitioners. Under the practitioners, you may now have non-physician practitioners, but they're still practitioners. So at that higher level, the logic is patients come to the healthcare system to see a practitioner. And then you have a huge support staff of non-practitioner staff that are there to enable all those services to be rendered, right? The practitioners get a little bit of a cushion when there's all this cost pressure on the whole health system, because that's what brings the patients in. And if you're a hospital VP, you look at that other bucket not as necessarily as a negative, but you look at it as that's probably where you're going to look for some cost reduction first, because you don't want to hurt the access to practitioners. That's what brings patients into your health system. If you were to take all non-practitioner staff in a healthcare system and rank them by salary, believe me, we are near the top of that list, right alongside the hospital VPs. So let's not kid ourselves that we wouldn't be in the crosshairs sometime. I'm sure several people in the room have had outside labor analytics firms come in and do a review of their hospital labor cost. One of the first things they do is exactly that. And one of the first conversations you have right after that is with your health system VP about why you need only board-certified physicists to do your work. Now let me switch to what I view as the potentially more positive sort of driver. In radiation therapy, the complexity just of the whole clinical process, it feels like it increases every year, mostly for good reasons. We're seeing rapid adoption of SBRT in the community, and in many cases, that as physicians get more comfortable with indications for SBRT, different disease sites, for instance, we're seeing retreatment of patients who would have perhaps not been retreated before, where now we can treat more focally and they're more comfortable with the technology, using that to retreat patients, which in turn leads to a more complex analysis of composite dose and different fractionation schemes and BED evaluations and tons of more imaging data, and now we get into deformable registrations of imaging and dose matrices, and understanding all the uncertainties that are inherent in all of that. And then you move to the treatment machine with motion management, where we don't just do IGRT anymore, we do fluoro while we coach the patient on breath hold and look for stable fiducial markers and so forth. So when you think about the whole radiation therapy process, there's a lot of what I'll call good complexity in the clinical workflow, where the QMP's role is essential for both getting the rest of the team up the learning curve, as was alluded to in the prior session on surface imaging, but even just to be there as the person with a broader background and the analytical skills to help evaluate a complex case when the therapy staff may just have a case of TMI and not really know how to process all the information in front of them. We need to be able to be available when those things come up. And in many cases, those things come up on the spot. And they're certainly always time sensitive when they come up. So how do we build the bandwidth to be available for these kinds of higher value, if you will, to the patient and higher visibility to our team interactions. And I would argue that one way to do that is to look at how do we safely delegate some tasks. So I mentioned the board directive. This is just a clip out of the board minutes from the 2014 annual meeting. And you can, obviously, any one of us can download those minutes. But here's the actual action item that was voted on at the time, that the APM develop an appropriate guidance on MPAs in supporting clinical medical physics work under the supervision of a QMP, including these 4 things: developing a practice guideline on supervision for MPAs, that's what we're talking about here, developing a position statement, which I'll show you in a moment, that's been done, interacting with regulatory and licensing bodies and other professional societies to advocate for our view on this whole topic, which once we have to have a consensus before we can go and do that. And then last but not least, developing the educational curriculum. And I'll just note, this was not a close vote. We have a pretty large board. We have one of the biggest elected boards probably of any organization. So we have a lot of diversity in our board. And yet that vote was 31 yes, one abstention. You probably can't read all this text, but I'll just alert you to the fact that we have a published professional policy on medical physicist assistants. It is Professional Policy 29A. So this was a direct follow-up to the board motion. And this is the full text of it, so it's not very long. You can go online and read it yourself. Obviously, with the professional policy being developed before we had the full MPPG available, this is necessarily somewhat generic. And professional policies have 5-year sunset dates and can be updated even earlier as appropriate. So we could certainly revise this once we have more guidance that we've reached a consensus on. But I think the important thing is the last sentence. All medical physics tasks performed by the MPA must be co-signed by the QMP supervisor who assumes full responsibility and liability for the submitted content. There's more wording in there, but so we've been working on this MPPG. Tony described the membership of the group. I won't belabor that any further other than to say, just again, I think it's a pretty good mix, pretty much equal imaging and therapy and diverse practice settings and definitely diverse perspectives. We've had some pretty healthy discussion. Here's my take on sort of the deliberations we have gone through to get to the current state of the draft document. One of the big ones we struggle with early on is, do we develop a document that's full of, that's prescriptive, that's full of lists of tasks that are okay to delegate or not okay to delegate? Or do we defer to the local QMP's professional judgment? So that was sort of a big decision point early on. And even that engendered a lot of discussion because some really wanted a list of things that should not be delegated. And well, that sort of then implies an opposite list, doesn't it? And so we had a lot of discussion around this. And in the current version of the draft, we came down on the latter, defer to the local QMP's professional judgment, set some very clear expectations of what thinking should go into the decision of what you delegate or don't delegate, or even whether an MPA is appropriate in your own practice setting, but to defer to the local QMP's judgment on that, not to come out with a list of tasks that a healthcare administrator would then take perhaps out of context and say, well, given that, I'm reassigning X percentage of all the scope of work that you guys do and hiring some MPAs. And also the levels and nature of supervision. I'll describe in a little more detail the general, direct, and personal levels, which are sort of the CMS terminology and how they apply here. But in this context, it was more, so do we mandate that a QMP has to be on site at each site of service, at least at a certain frequency, or not? are there certain things, and perhaps more on the imaging side, that are straightforward enough that a QMP doesn't have to go to that facility regularly. And this involved a lot of discussion too. How exactly do you supervise? Do you need to be in every procedure room in person and lay eyes on things? Because there are definitely things that a trained physicist will pick up on only by being present, right? You may look at the test results of something and that may all look okay, but you go into a procedure room and you say, why is that gizmo there? Wait a minute, how do you guys use this? And then it gets into a conversation where you realize that someone is not understanding the purpose of a test or how a piece of equipment is supposed to be used. You can only get that from being present. And so there was a lot of discussion around this point. And then if we don't do lists, then there was sort of a second go-around at the lists. Okay, how about if we define certain parts of our scope of practice document as absolute no-go zones? Well, that's sort of getting into a list again, isn't it? So we had a bit of a second round of that. And then the one that caused everyone the most grief, the ratios, as Tony already spoke to. So to me, those were kind of the big discussions that we've tried to work through. So with that said, I'm going to move to showing you some of the language out of the draft document. I had anticipated that the draft document would have been open for member comment as of today. So my apologies for the fact that I'm showing some of the actual text of a document that perhaps I shouldn't have had copies of on the slides here, given that it's not out yet. We typically wait until it's out for member comment before we show text. Tony did a better job than me in scrubbing his slides, but I just found out as I walked in here that was the case. So here's from the introduction as it, again, draft in big letters here, okay? But this is what I found of interest from a therapy perspective, again. We set, I think, the tone pretty clearly here. The design and management of a medical physics practice must principally be the responsibility of a QMP, not anyone else. And taking into account local circumstances and resources, there may be certain tasks that the QMP determines can be delegated. Not an administrator, the QMP determines can be delegated under their supervision. Such delegation does not absolve the QMP of the legal, ethical, or other professional responsibility for the quality of the medical physics practice. The delegated task is in all ways the responsibility of the QMP. I felt the need to read that out because I think if you read that paragraph in its totality, that's a pretty clear expectations. A few more. So Tony already gave the definition of the MPA, so I won't reread that. But just to restate that it's a physicist assistant. Supervision. So we've thrown these terms around: general, direct, and personal. And we use those terms because that is the sort of accepted terminology that CMS has been using, Centers for Medicaid and Medicare Services, and pretty much all the specialties, medical specialties, then adopt those terms and then define what that means in their practice setting. And so here it is for us. So in the case of the MPA, general supervision would mean that medical physics activity is performed under the QMP's overall direction and control, but the QMP's presence is not required during the performance of the activity. Direct would mean that a QMP, in addition to that, has to be present in the facility and immediately available to furnish assistance and direction. But you don't actually have to be in the room when it's being performed. And personal means just that. You are present in the room live while the procedure is being performed, while the task is being performed. So those are the three levels. I just think we need to all understand what they are. When we say general, that does, yes, mean that a task could be performed when there is no physicist on site. So we want to be really, really careful about where we allow that. Direct means you're available, and you better be available, meaning You can't say, well, I'm scheduled on site, but I'm tied up. I'm not available. I'm tied up in very important meetings. I can't be interrupted. That's not what direct supervision means. It means you page me, I'm there. If you have a problem, I'm going to come in the room and help you analyze what the issue may be. And personal means you are in the room. And then some other language here. A QMP must not delegate a task to an MPA that would increase the risk of harm, and that in determining if it can be delegated, what the QMP takes into account likelihood of error, severity of the impact of potential error, and likelihood that an error would go undetected. Sounds a little bit like TG100 to a therapy physicist, but that's sort of the same logic here, right? Think about failure analysis and the potential risk of any one failure. We had a bit of discussion even about this first bullet. Are we going to require that baseline measurements have been performed by the QMP and the protocols have been established before any task is performed by an MPA? And we've settled on that. And yes, that means that for even the simplest of tasks, a QMP must have touched the equipment first, tested it, set the baseline, and set the protocol to be followed. And that they've demonstrated competence, which I'll touch on a little bit more here in a moment, and that the MPA actually complies with the supervision plan, of course. So a lot more language here about the supervision responsibility. Just stress the last a couple of things here. One, depending on the task assigned, there needs to be periodic interactions between the QMP and the MPA, and at some frequency. So again, this is what needs to be articulated in a written supervision plan, and it will depend on the task, and it will depend on the level of training of the MPA and so forth. So this is why we want to defer to the local QMP's professional judgment in setting this. But the expectation is very clear. The QMP still reviews and signs all work. In no circumstances can the authority to sign be delegated if the work is performed by an MPA. It's just a no-go. The record should indicate who actually collected the information and who prepared the report. So it needs to be transparent about how the work was done. And overall responsibility for the supervision plan resides, of course, with the QMP. Then we get to the infamous table. So this is the one that's given us the most grief for sure. And as Tony said, we kind of stuck to our guns on the therapy side at least I'll give you my thinking. There are, in my view, too few tasks that can safely, or at least comfortably in my mind, be delegated to warrant a ratio higher than this. I alluded to the clinical workflow earlier and the physicist's involvement. There's no role for an MPA in any of those things that I mentioned there. There's no role, obviously, in things like output calibrations or in things like evaluating images that are, say, on an OBI system. If you're having a question about either isocenter alignment of the imaging system and the MV system, or arm sag that's giving strange cone beam artifacts, this is not something that you task an MPA to do. Collect the data so that we can begin to analyze it, yes. Interpret it, no. And so, in my view anyway, if you go through kind of the normal plate of things that a therapy physicist has to do in a given week and month in his routine work, there simply isn't enough of that I would be comfortable saying we could even, with structured approaches, delegate to anyone to warrant a higher ratio than this. Furthermore, and this is the one I've highlighted here, we've said that it is inappropriate to use an MPA in a practice setting that does not have a full-time QMP presence per location. And the per location was a result of a lot of discussion as well. Could you have let's say, a practice with 4 locations each location being fairly limited in volume of patients and procedures, and therefore maybe only have 2 physicists on staff covering 4 locations, it would not be appropriate to hire an MPA in that setting, because you're not going to have the interaction on an as-needed basis when something comes up and the MPA needs assistance. And again, most of the scope of practice are things that we need to retain. So we've said that here, that it is inappropriate to use an MPA in a practice setting smaller than that. So this effectively means, as Tony said, that we're really talking about somewhat larger group settings for more physicists to fill a full-time position in few geographic locations, so that there is always a physicist available to supervise the work. I pulled this language at the bottom here, which is actually earlier in the draft document, but in this context here, I thought it was important that we set, again, a pretty high bar there for the physicist and, frankly, for the administrator who might read this document, that billing for professional services often entails an implied or explicit requirement that the services are performed by a qualified medical physicist. Failure to provide the appropriate level of QMP engagement is unethical, frankly, and may be deemed illegal. You may be paying back a lot of money if your facility bills for services that involved a significant QMP labor component, and you didn't have a QMP present to do that work. So I think we need to be mindful of that there's a lot of QMP labor time built into many therapy codes on the therapy side. We better understand what that is and not risk undermining all of that in the global sense, where CMS says, all this work can be done by someone else, or in the local sense where, frankly, you're knowingly or not committing billing fraud. So it's something to be very, very aware of as you look at whether it makes sense in your practice setting to use an assistant and to delegate certain tasks. And I think this may be my last slide. On the competency piece, we have a whole section on that, but I've highlighted this portion here, that the MPA must demonstrate the ability to consistently, correctly, and accurately perform each task, and must therefore perform the task under the QMP's personal supervision in order to establish competence. Note the term here, personal supervision, as used in CMS parlance. So this means you have to have trained the person, in the room, and as many times as you need to be comfortable attesting to that person's competence to consistently, correctly, and accurately perform a task. Consistently means more than once, doesn't it? So this does mean not to be taken lightly. When you attest to an MPA's competence, you have trained them, you have observed them directly, and you've done that more than once. And I would add, though it's not explicit in this language, that may also be per practice setting. So there may be a task that you've observed in one practice setting that the person can do just fine, and a nominally same task, but performed with different equipment in a different practice setting. If I would posit that you better go there and be on site and see that individual understands how to do that task in each setting. So the responsibility is ours, folks. We can't shirk away from that. If you choose to delegate certain tasks, it is still on each of us. And I think that we need to be vocal with our administrators as well if we feel any undue pressure on us to delegate work or to use assistants, that we need to be able to speak clearly about the risks and the obligations professionally. And in that context, I think it will be helpful to have as close to consensus as we can get, practice guideline document to refer to and say, well, this is the position of my professional society on this. This isn't just me arguing with you. And I think it's in that context that an MPPG on this topic can be helpful. It doesn't absolve any of us of advocating within our organization for whether this is appropriate in our setting or not, and if so, how to do it. But at least gives you a strong reference, I hope, to be able to have that discussion with your senior administrators. And I think that was my last slide, so I will stop there.